Good afternoon, everyone, and thank you for joining us today. And I'd like to introduce Professor Mushtaque Chowdhury. It's a great honor and privilege to introduce him, actually. Dr. Chowdhury is the former vice chair of BRAC. So a lot of people from Bangladesh and globe already know BRAC, but for those who may not know, it's actually the world's largest non-governmental organization, known for its significant contributions to alleviating poverty, empowering communities, and improving the health and well-being of the people across the globe in several countries, maybe 12 countries if I'm not wrong. His remarkable career has seen him at the helm of BRAC's Research and Evaluation Division, as the founding dean of the BRAC James P. Grant School of Public Health, and several other institutions in Bangladesh and abroad. His academic journey has taken him to prestigious institutions such as Columbia University, where he serves as a professor of population and family health. Dr. Chowdhury's work hasn't gone unnoticed, having been recognized with a Medical Award of Excellence by Ronald McDonald House of Charities, and being honored by the famous journal, the Lancet journal, for his contributions to global health. He received numerous other accolades, as far as I know. He's a visionary founder of Bangladesh Education Watch and Bangladesh Health Watch. It's a watchdog on the health activities in Bangladesh. And his leadership extends to numerous boards and committees across the globe. Dr. Chowdhury is also a prolific writer with more than 200 articles, multiple books, etc., mostly reflecting on public health, epidemiology, and the rich tapestry of his own personal experiences. His academic credentials are also equally impressive, with a PhD from London School of Hygiene and Tropical Medicine, an MSc from London School of Economics, and a BA in Statistics from University of Dhaka. So please join me in welcoming Dr. Ahmed Mushtaque Chowdhury to enlighten us with his speech. I welcome Professor Mushtaque Chowdhury, please.
Thank you, Tawfiq and Harshini, for this very kind and elaborate introduction. I am so delighted to be part of this NUS program. The title of my talk talks about the Southeast Asia, how transforming health in Southeast Asia. And there I want to sort of concentrate more on the book that Harshini mentioned, which has come out only last year, on the last 50 years of Bangladesh, particularly in the sector of health, how Bangladesh has done, and what Bangladesh could do, and what is there for it in the future. But before that, I want to sort of mention that I have a great interest in Southeast Asia, and just to say that I spent 4 years in Thailand, starting in 2009 to 2012, where I was the acting managing director and head of health for the Rockefeller Foundation in Asia, and that gave me a lot of exposure to what is happening in Southeast Asia, and then the rich history, particularly in the health field, that the different countries in Southeast Asia has. One of my first assignment at the Rockefeller Foundation was to work with the Lancet series on Southeast Asia, which was started on the day actually I joined the Rockefeller Foundation, and Rockefeller, along with the China Medical Board, were the main supporter of this initiative. So I worked very closely with China Medical Boards, President Lincoln Chen, the Lancet's Bill Summerskill, and I still remember very clearly the first meeting I had in Indonesia, in excuse me, in Gajah Mada, that sort of kick-started the Lancet Southeast Asia series, which was finally published and released at the Prince Mahidol Award Conference. I think it was 2010. But while in the Rockefeller Foundation, I had the opportunity to visit almost every country in Southeast Asia, and I was really sort of very impressed with the progress that the region has been making, and particularly how the different countries in the region are working together for common good, which is health. And I still remember the work that was initiated about 3 decades ago on the called the MBDS, the Mekong Basin Disease Surveillance, which was started probably about 1999, and which sort of connected 6 Mekong countries for disease surveillance. And one of the reasons that we have seen the Southeast Asian countries, the Mekong countries, doing much better than the rest of the world during the pandemic was, I think, this disease surveillance that has been in place for the last 3 decades. So I I'm very interested in the way the Southeast Asia has made progress in health and in different areas. While I was at the Rockefeller Foundation, I also had the opportunity to work intensively in Vietnam, which is one of the South Asian countries, and I sort of helped set up several institutions there, including the Center for Non-State Sectors at the Hanoi Health Strategy and Policy Institute. Also, I worked with the Hanoi School of Public Health and the Hanoi Medical University. I also helped to set up a master's in health economics program at the Ho Chi Minh University of Economics. So these are some of the memories I still have about Southeast Asia, and I fondly remember all of these memories. Uh, so with these initial words about Southeast Asia, I move to the main topic of my presentation today, which is presenting the book called the 50 Years of Bangladesh, Advances in Health. And in this book, we are actually, as I mentioned at the outset, have sort of tried to document the different improvements, the changes that has happened in the health sector in Bangladesh over the last 5 decades. And in order to make sure that the changes that we see are explained, we also have compared those changes with those happening in some of our closest neighbors, such as Pakistan and parts of India. This book has 20 chapters, as I will come back later, and has the contribution of more than 100 authors. I was one of the editors only. So the main contribution to the book is given by is by 103 authors. So with this, I move to my presentation. I request Ashwini to sort of show the slide, please. Start with the first one, which was there already. Then the next one, please. Keep going. Okay. So we are talking about Bangladesh, and Bangladesh has been in the world headlines over the last several years because of some of the changes that has happened in the country over the years since 1971, when Bangladesh was liberated. When Bangladesh became independent in 1971, it was the second poorest country in the world after Burkina Faso. But now it has sort of come a long way. Please go back. Yeah, thank you. Bangladesh has now birthed into a developing country status. In 2026, the World Bank and the United Nations will declare us as part of the developing countries. We know Paris as the fashion capital of the world, but because of the improvements that Bangladesh has made over the years, Bangladesh is now thought of as the capital of development, and many people go to Paris to see fashion, and we see that many people from around the world are coming to Bangladesh to see what Bangladesh has done over this period and how it has done so. There has been a lot of writing about these changes that has happened in the world press, and I'm sure many of you have heard about the New York Times and its columnist Nicholas Kristof. So when Biden became the president about 4 years ago, Nicholas Kristof wrote a op-ed in the New York Times in which he advised President Biden to look to Bangladesh if he wants to remove America's poverty, particularly for the children. So this one is an indication of how much the world press, the world media has been focusing on the country over the years. Bangladesh is also known for its for the presence of many of the successful NGOs in the world, but there is also a paradox there. Bangladesh has made good progress, but as the Lancet, which published a series on Bangladesh development in about 10 years ago, the editors of the Lancet, while analyzing the changes that has happened in the country, mentioned that the Bangladesh story is one of the great mysteries of global health, because given the situation there, given the challenges that Bangladesh was facing, such changes were not very much expected. So there is a paradox that Bangladesh has made such an improvement despite all the other problems, which I will come to momentarily. But Bangladesh has made progress, as I will show, but also there is hardly any room for complacency. We have a long way to go, and we have a huge number of challenges that we have to face in the next 50 years. Next, please. So this is about Bangladesh. As you know that, as I said, it became independent in 1971 after an armed struggle, which led to about 3 million people being killed in the liberation war. Bangladesh is probably the 8th largest country in the world with 170 million people, and it is the most densely populated country in the world, except for Singapore and similar other island nations, so this density of population is only an indication of the kind of problems and problems the country has. But Bangladesh has actually taken this as a kind of a blessing in the sense that because of the large population, we are now able to export many of them to other countries who are sending remittances, which is one of the mainstays of our economy now. So Bangladesh is still a rural country with 60% of the population living there. And Bangladesh, as I said, that has improved economically, and the GDP per capita is close to $3,000, but which is compared to most countries in Southeast Asia is still very low. I mean, I don't want to compare with Singapore's 82,000, but even countries like Malaysia, for example, has a GDP per capita of 12,000. So Bangladesh is still very poor compared to most of the Southeast Asian countries. Poverty is still there. About a quarter of the population are poor by any standard, which means that about 40 million people in Bangladesh are poor, which is absolutely unacceptable. The literacy rate is improving. It is about 70% now. And the other distinguishing feature of Bangladesh is that it is at the forefront of climate change. I mean, we have all the sort of the symptoms of climate change that one can imagine. Next, please. So this one shows the changes that has happened in different mortality rates. Not, thank you. And as you can see that all the mortality rates have shown sort of constant decline over the years since 1970. And the most remarkable decline has happened in the maternal mortality ratio, which is given at the top one, the black line. So in the early 80s, for example, Bangladesh had a maternal mortality ratio of 650. But by 2010, it came down to less than 200. So it was a huge improvement in such a short time. With respect to other mortality rates, for example, the infant mortality rates, the under 5 mortality rates, and the neonatal mortality rates, all have been showing decline. Although the decline in the neonatal mortality has been slower than most other rates. The red line is the life expectancy at birth. And as you can see, we have been sort of seeing a constant improvement in life expectancy. The next two slides, I will be sort of concentrating more on the life expectancy experience of Bangladesh. Next, please. Oh, this one, before I move to the life expectancy, I wanted to share with you the fertility rate, the total fertility rates in Bangladesh. And as you can see that when Bangladesh became independent in the 70s, Bangladesh and Pakistan had very similar fertility rate, about 6.6 per woman. And as you know, the total fertility rate is the number of children that women leave behind when at the end of a reproductive period. And as you can see that Bangladesh has made huge progress in reducing the total fertility rate from 6.6 to which is now about 2.3, which is just above the replacement level. But we also have included another graph here, which is from West Bengal of India. Bengal is divided into two parts, which is the major part has come to Bangladesh, and the other part is now part of India, which is West Bengal. And while sort of documenting the progress Bangladesh has made, we thought that we should compare the Bangladesh experience with our neighbors. And here comes West Bengal. And as you can see that the experiences of West Bengal has been better than Bangladesh and Pakistan all through. Although, as you can see, that what is important here is the gap. So in 1975, the gap between West Bengal and Bangladesh was about 2.4 in terms of the total fertility rate. But now in 2020, although West Bengal still has a lower fertility than Bangladesh, but the gap has come down significantly. Next, please. So this is the first of the two graphs on life expectancy at birth in Bangladesh. And here we compare the experiences of Bangladesh with some of our neighbors or some of our closest neighbors. And as you can see here, that Bangladesh and Pakistan and also India started about the same with a low life expectancy, but over the years all have improved. But Bangladesh has actually surpassed those of India and Pakistan, and this is a major improvement that the country has done over the years. The life expectancy of in Bangladesh is about 73 now. I also have included the life expectancy experience of Sri Lanka here. As you can see that the Sri Lanka has been maintaining a high life expectancy compared to other South Asian countries, and their lead in life expectancy is still there. But as I was mentioning others while I was talking about total fertility rate between Bangladesh and West Bengal, here also, if you look at the gap between Sri Lanka and Bangladesh in 1960 and compare it to the same gap in 2020, you see that in 1960 the gap was about 15 years. But now the gap in life expectancy between Bangladesh and Sri Lanka has come down to about 5 years. So although Bangladesh hasn't been able to really reach the level of Sri Lanka, but it is catching up. But it also shows that that although Bangladesh is very happy that it is doing very well, but also that there is no place for complacency because Sri Lanka is another of our neighbors, and they are doing much better than what we are doing, and we have a long way to go to in order to catch up with Sri Lanka. Next one, please. This is an interesting graph as I compare the life expectancy of male and female over the years. And many of you know that Bangladesh was one of the 3 countries in the world until about 20 years ago, where women lived a shorter life than men. Biologically, traditionally, historically, the female live longer than male, but that was not the case for Bangladesh, and the reason for that was many people said that it was systematic neglect of girls and women in the country. But as you can see that this gap between men and women has been eliminated. It has been corrected. So if you look at 1960, the men were ahead of women in terms of the life expectancy, but in 2020 this has reversed, and now the life expectancy of women in Bangladesh is about 3 years more than that of men. So this is a huge improvement, and and shows in some way the improved life that women have been sort of exposed to in recent times in Bangladesh. I will come to this gender issue later on. Next, please. In terms of also the nutritional status, I mean, we have been seeing improvement in both the starting rate, which is given in the green graph, and also the proportion of children who are underweight, and both of them are showing actually marked improvements. But one thing that I must mention that it is also true that 31% of Bangladeshi children are stunted. This is absolutely unacceptable in this 21st century. So although Bangladesh has done well, but there is a long way to go. We have to sort of make sure that our children are not stunted, as you could see here. Next, please. So as I said that there is a paradox there. So Bangladesh has done well, as I was trying to portray through those sort of slides earlier. But these have happened despite some of the challenges, some of the problems that the country has. So Bangladesh has one of the lowest investment in health. Only about 0.7% of the GDP is spent on health. And this is probably the second lowest in the world after South Sudan. So Bangladesh's investment in health is very, very low. And this has led to some of the researchers writing a book called the Good Health at Low Cost. So we have achieved good health at a very low price. But if we want to really move forward from here, this has to change, as I will come to this later on. Also, we have an expanding private healthcare sector, which has been sort of received a boost in the early 80s when the government sort of made good changes in the way the private sector could invest in healthcare. But this has remained largely unregulated. And if you look at newspapers, every day there are stories of how the private healthcare sector is really sort of creating problems, particularly in the way the healthcare is done and how the poor people are becoming poorer because of the private health sector. These changes have happened in the country despite the poverty, which is about quarter, and also more importantly, the poor governance that is there. And we are aware of the issues of the absenteeism. And there was a study done about a few years ago, which looked at the presence of doctors in the emergency obstetric care facilities in the country. And in those facilities where it is critical that you have doctors and the anesthetists there 24 hours. The study found that only 39% in only 39% of these facilities, these emergency obstetric care facilities, have these critical sort of human resources for 24 hours, which means that that there is a huge governance issue there. which the country has been grappling with for a long time. And we know of the corruption. I mean, during the last pandemic, this COVID crisis, we have seen how the corruption has really engulfed the entire health sector in the country. So the question is, how Bangladesh has done so well despite all these problems. And what I am going to do now is to do an analysis of the reasons, and I divide them into two parts. One is the more sort of direct health-related interventions that have happened over the years, which may have resulted to some of these improvements, and also that there are improvements in the social determinants of health. As you know, that many of the improvements that we see in the health sector is not necessarily the work of the health sector alone. The social determinants of health, the other sectors of development play also a very important role in improving health in any society. Next, please. So the first is what were the sort of direct health-related intervention that has happened over the years in this country. And we know that there has been a huge expansion of health facilities and services in the country. And the latest in this is the setting up of about 14,000 community clinics, which is sort of a facility which is available for every 6,000 population. Although there are many sort of challenges that these community clinics are facing in order for them to be more useful, but the facilities, these infrastructures are there to provide services. Also, I mentioned about the private healthcare, which has expanded tremendously since the early 80s. And one of the major intervention that has really made a big difference was the enactment of the drug policy in 1982. And Bangladesh was probably the first country in the world, in the developing world, where a drug policy was enacted. And this made the essential drugs easily available. And many of these harmful drugs were disbanded. And this led to at least two impacts. One was that the essential drugs were easily and cheaply available to the people, even in the remote areas, through these pharmacies, and also that this also sort of led to an explosion of pharmaceutical industry in the country. And Bangladesh is now almost 98% self-dependent on pharmaceuticals. We don't need to import. And Bangladesh, but in addition, Bangladesh also exports the pharmaceutical to over 100 countries in the world. So it is now becoming one of the major export items for the country. The other direct health-related interventions was the training of paraprofessionals. And Bangladesh, like many other countries, was considered as a kind of a crisis country in terms of the health workforce shortage. The shortage was immense, and so Bangladesh decided that they will, without waiting for the doctors and the nurses to be trained, Bangladesh decided to train community health workers with short training. And thousands of community health workers were trained. And BRAC, for example, trained over 100,000 community health workers. And uh, the inspiration for community health workers came actually from China. As you know, that China started the barefoot doctors program back in the 60s, which really contributed to China's sort of big sort of revolutionary changes in the health status of its population. Also in 1978, as you know, that there was this international conference on primary healthcare, which happened in Almaty in Kazakhstan, and that conference also sort of called on the countries to train with community health workers in order to meet the 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 shortage of the more trained doctors and nurses and midwives. And after the Alma-Ata conference, there were huge interest in the community health workers. And as you know that this was the many countries experimented with community health workers, and unfortunately, not many were very successful. So one of the successful ones, which happened in Bangladesh, and so in any community health workers program, there are two issues which need to be solved. One is that it has to be connected to an existing health system, whatever the faulty the system is, but there has to be some connection between the community health workers and the system that is there, and also that there has to be some incentive for the community health workers to sort of work, because most of these community health workers are women and they are from the poorer families. So they need some incentives to continue working on that. And BRAC sort of took this up, and they connected the community health workers with the BRAC health system. And and every month, the BRAC sort of brought all the community health workers to its office for a refreshers training. So this way, the link between the system and community health workers was maintained. And also BRAC built several incentive systems for the community health workers, which included, for example, membership of the microcredit group. So through that, they were given the opportunity to sort of get money for some economic activities. So the training of paraprofessionals actually happened in Bangladesh, and that is said to be one of the major reasons why Bangladesh was able to really do so well and connect with the community so easily through these community health workers. The other health related reason is the research. And Bangladesh, fortunately, has an institution like the ICDDRB, which is one of the top research institution in the world, which was set up back in the early 60s and has been doing research on cholera, but has also expanded its activities, its scope to other areas of healthcare, including family planning and nutrition and others. So ICDDRB's research has been very instrumental in making the healthcare services more responsive to the need of the community. BRAC also has had a large research division, and the BRAC research concentrated more on implementation research. So BRAC is an action NGO, and they implement programs in the villages. So the BRAC research actually tried to connect the BRAC programs with the evidence, that's how the BRAC research is distinguishable from other researches. Bangladesh was also fortunate to implement many of the demographic and health surveys. So every 2 years, almost every 2 to 3 years, we have a DHS here in this country, which really helps to see changes that are happening. And this itself is a big kind of a push for the government to see how much changes that are happening in the health sector. So research actually played a very important role in the way Bangladesh has progressed in health. And finally, in terms of the direct health-related interventions, are the many public health actions which are carried out at scale throughout the country. And we have had the malaria eradication program back in the 70s, and we don't have malaria anymore, except in the few sort of 5% of the country where we border with Myanmar and India. So apart from that, Bangladesh is almost free of malaria, almost. Although we sometimes we get reports of malaria happening in country as well. So Bangladesh also has this very successful family planning program. And Bangladesh is a Muslim country, but the family planning acceptance rate, the contraceptive prevalence rate, is over 60%. So this is a big kind of a achievement that has happened, and here both the government and the NGOs have played a very important role, and that started back in the 70s after the independence of the country, when Bangladesh declared that overpopulation was the #1 problem for the country, and the government chalked out different programs. And also, I must mention about the role of some of the donors in this, the USAID, the World Bank, and many other donors. They came forward and supported the family planning program of the country. Also, we have had a huge number of programs on water sanitation. Until the 1990s, every person in this country had access to safe water. But in 1992, we found that the water that we were drinking at that time had arsenic in it. Many of these hand pumps had the arsenic. So this made a huge sort of change in the way we have been thinking about safe water in this country. And so we have made good progress in water, but the arsenic problem still remains there, and it is kind of a forgotten problem for the country. Bangladesh is also a country which has a lot of tuberculosis patients, and we have been very successfully using the DOTS procedure for many years. And one of the sort of unique feature of the TB program in Bangladesh is the inclusion of the non-governmental organization. Bangladesh is probably only one of its kind in the world when an entire national program has been handed over to the NGOs to implement, with the oversight and drug supply and supervision being carried out by the government. So this is quite a success story as well in Bangladesh. And I'll come to the vaccination work in the next 2 slides. Next, please. Bangladesh is a success story with respect to the promotion of oral rehydration therapy for diarrhea. Bangladesh in Bangladesh, major cause of death was diarrhea, particularly for the children. And in and as you know that ORT is the treatment of choice for diarrhea, and the ORT was discovered in Bangladesh at the ICDDRB. And in the early 80s, BRAC, the NGO, they decided to make the information and the knowledge about ORT available to every woman in this country. And BRAC trained thousands of workers, female workers, to go from house to house and teach mothers about how to make ORT at home with salt and sugar. And this is one of the major reasons why the use rate of ORT in Bangladesh is the highest in the world. About 80% of the diarrhea cases now are given some form of ORT. So this is another major kind of a achievement that the country has done over the years. Next, please. And the other big intervention that successfully Bangladesh carried out was the vaccination. And in the mid 1980s, the vaccination rate, the immunization coverage in Bangladesh was about 2% only. So at that time, Bangladesh decided to really invest more in this, and they invited the NGOs, the private sector, the media, the donors, and so on, to really give it a push. And in 5 years, we saw that the immunization coverage rose from 2% to 70%. So this was such an improvement in such a short time that not many places in the world has really experienced. Now, for example, Bangladesh has an immunization coverage of more than 90%. When this program was started, it was a vertical program, and there was a lot of question about vertical programs at that time. But now Bangladesh has been successfully able to really integrate the immunization program within the health system. So this is a major success story for the country. Next, please. Now, those were some of the reasons that I see which are more health related. But as I said, that the changes in health happens not only because of the actions on the health front, but also on things which are related to health, which some people call the social determinants for health. And there has been a lot of development in those actions that I wanted to share with you. Here you can see three pictures. The one in the left is women workers in the ready-made garments factory. Bangladesh is now the second largest producer of ready-made garments in the world, after China, and this has become the lifeline for the country's economy. And here about 5 million workers are there, most of whom are women, and they come from the rural areas. So this has actually revolutionized many of the lives of the women in this country. I mean, they really have a new vision for life, and so on. The middle one is the school. I'll come to this later. And the right one, the one in the right is the newly constructed the Padma Bridge, which is the largest, the longest bridge in this country, which was commissioned about 2 years ago. Uh, and so one of the questions that may be asked is how a thing like bridge is connected to improvement in health. Uh, uh, we know that, I mean, if you take the case of maternal mortality, uh, we knew that maternal mortality, in order to sort of reduce maternal mortality, you have to have the emergency obstetric care available when the emergencies happen. Bangladesh has been investing in that, but it hasn't been possible for the country to set up these emergency care centers everywhere where it is needed. And also there are problems of sort of having them functional 24 hours. But still we see that maternal mortality has actually gone down significantly. So why is that? And one of the reasons is that although the emergency care is not available within the sort of quick reach of every area in the country, but because of the roads and the waterways that have been sort of so improved over the years, there are transportation available because of the empowerment of women that has been done. The status of women has been raised. So the family quickly can take the emergency cases to the nearest emergency care facilities. So the infrastructure played a very important role in this. Next, please. I mean, I mentioned about the GDP and Bangladesh has improved its economic standing significantly, and the GDP has our GDP has actually exceeded those of Pakistan and India. Next, please. Here I'm talking about the gender issue. And one of the reasons that has been mentioned that has happened in this country is the empowerment of women. And one of the indices which is used to understand what is going on in a society is the construction of what is called the gender gap index. And the gender gap index is a function of 4 parameters, as you can see here, which is economic participation and opportunity, the educational attainment, the health and survival, and political empowerment. So based on those, this gender gap index is constructed. And as you can see here, I have included the gender gap index for many countries in this region. I mean, I have included the South Asia, Bangladesh, India, and Sri Lanka, and also I have included 5 countries from Southeast Asia: Thailand, Vietnam, Indonesia, Malaysia, and Singapore. And as you can see that the gender gap index for Bangladesh is this country is ahead of every other country except Singapore. So which shows that the country also has made good progress in improving the status of the women in the society. Of course, I mean, some other countries in the region are lagging much behind, but Bangladesh as a country has made good progress with respect to improving in sort of increasing or improving the gender gap index for the country. Next, please. So the The other in the social determinants of health is obviously the issue of food and the agriculture. The improvement in agriculture production has been tremendously favorable over the years. The rice production, for example, has increased tremendously over the years. When the population has about 2.5 times doubled, but the rice production has actually increased about 4 times. So, which means that the per capita availability of food has increased quite significantly, and this has also obviously has had a huge impact on nutrition and consequently on health status. Next, please. We have seen a huge expansion of the in the education sector, particularly at the primary and girls' education. Now, about 95% of the children actually get enrolled in primary schools, which was much less than 50% at the time Bangladesh became independent. And more important here is the share of the girls. The girls' enrollment was always lower than the boys, but it has actually changed. Now there are more girls in schools than boys. So Bangladesh has made good progress in education. Although there are a lot of questions about what is next, particularly with respect to the quality of education. We have numbers. We have a large number of people, large number of children going to school, but how much and what they are learning in those schools is a big question, of course. The other issue is the natural disasters, which is an outcome of the climate change, I suppose. And the resilience against natural disasters has increased significantly over the years. And I want to mention here one of the major natural disaster that happened in 1970 when the country was ravaged by a cyclone. That cyclone in 1970 killed 500,000 people. But over the years, the country has invested in improving the situation there in order to protect the population. Thousands of cyclone shelters have been set up. Also, thousands of sort of volunteers have been trained on how to deal with in emergency. And if we compare with what happened in 1970, when 500,000 people died, if we compare with what happened in the last couple of years, there were similar cyclones about 2 years ago, and the number of casualty was about 200 only. So this shows how much the country has actually progressed in terms of meeting the problems that is created by natural disasters. And to us, one of the major reason, of course, for what has happened in the country since the independence was the impact of the War of Liberation itself, because the war itself was not only a war for a piece of land or for a flag, but it was a sort of it led to a lot of societal change in the mindset, and also in the national priorities, and also in the actors who sort of lead development. So, for example, before 1971, there was hardly any large NGOs, but the war resulted in the setting up of of hundreds of NGOs, many of which are really big. Next, please. I have come almost to the last part of my presentation, and the other sort of important part of this story is the role of the non-governmental organization. And as I just been saying, that there are thousands of them in Bangladesh, and all of them are actually doing a sort of improving the quality of life of the people who are vulnerable, the poor, the women, and so on. And many of these programs that are run by the NGOs are really large-scale programs. But then there are also questions about so the NGOs are running large programs. So what have they been able to really sort of make any measurable change in the lives of the people? So with the help of the ICDDRB, there was a study done in the 90s to look at the impact of BRAC's microfinance program on the health of the poor people in the villages. And as this graph shows, that the experiences of the members of BRAC's microfinance program in terms of child survival is much better than those poor people who did not join BRAC, which is the orange line. But also the other important thing that you can see here in this graph is that the experiences of the BRAC members is almost equal that of the richer section in the community. So one of the major challenges of today is we know that there are health inequalities all over, but what do you do about that? So this is one of the very few examples where it shows very clearly that the programs which sort of target women can actually remove inequalities in child survival. Next, please. So continuing on the contribution of NGOs, here is an example from BRAC, and which is one of the largest NGOs, as Tawfiq was saying at the outset. It reaches more than 100 people in about 12 countries in the world. And BRAC's view of development is that poverty is a sort of it has many reasons why people become poor. So in order to address poverty, you have to address all the causes of poverty, and that's precisely the reason why BRAC has taken large programs in education, in healthcare, in environment, and women's development, and so on. From day one of BRAC, they have been very concerned about sustainability, and they have been investing in social entrepreneurship. And if we look at the budget of BRAC, you see that 80% of the budget of BRAC is self-dependent. BRAC generates its own income for 80% of its projects. So it's trying to become self-dependent as much as possible. And BRAC is known for innovations. I have talked about, for example, the oral rehydration, but also there are innovations that have been done by BRAC in every sector of development. And BRAC is an organization which is evidence-based. So BRAC has invested in research and particularly in implementation science. Next, please. as I was saying that Bangladesh has made good progress, but there is hardly any room for complacency. And here I sort of try to uh, uh, justify this contention uh, by by uh, by comparing Bangladesh with Sri Lanka and also Norway. So with respect to maternal mortality, for example, Bangladesh has a maternal mortality rate ratio of 176. But compare this with Sri Lanka, which is our almost next door neighbor. And Sri Lanka's maternal mortality ratio is only 30, and not to speak of Norway, which has 5, of course. Which means that we have done well, but there is no reason why we should really be complacent about it. We have a long way to go, and even if we want to catch Sri Lanka, we have to sort of go a long way. Next, please. And finally, we have the SDG. Bangladesh is a signatory to the Sustainable Development Goal of 2030. And also Bangladesh wants to become a developed country by 2041. But there are huge challenges in order to sort of attain that. Bangladesh did quite well with respect to the MDGs. Many of the MDGs were achieved. And those were possible mainly because Bangladesh was able to really harvest the low-hanging fruits, which were easy to do, the ORT, the immunization, family planning, and so on. But in order to move further, Bangladesh has to really look to new solutions for the higher hanging fruits. And those higher hanging fruits would include things like the NCDs. About 65% of the deaths now are through the NCDs, the cancer, the diabetes, hypertension, and so on. The urban issue becoming more and more important, but unlike the rural areas, we don't have a model for urban health yet. And we have the climate change there. Bangladesh is said to be a sort of a success country in terms of the adaptation for climate change. But the health consequences of climate change will have to be understood. We are seeing sort of re-emerging diseases like dengue, for example. It has killed many people last year, and there is no we haven't been able to really address this very well. We have the road traffic accident, which is sort of taking the lives of many people. Malnutrition still is a major problem. And we have a very high out-of-pocket expenses, which is 67%. So 2/3 of the expenses that people incur in healthcare is from their own pocket. So this is one of the highest in the world. And as I said earlier, that we invest very little in health, less than 1% of GDP, so which has to be increased in order to reach the new targets that we have for us. Also, we have to improve the governance, and also we have to really give attention to the private sector. We have thousands of pharmacies, also the informal providers, the clinics, and about 100 medical colleges. And there are a lot of questions about the quality of education in those institutions. We are also seeing rising inequalities, and one of the indices through which inequality is measured is the Gini coefficient, as many of you know. And the Gini coefficient for income has been rising. So about 10 years ago, it was 0.45. Now it has gone up to 0.49. So the inequality in income is increasing very fast. So it's a major area of concern for the country. And the government has uh, uh, has committed itself to attain universal health coverage by 2030, the SDG target. But there is hardly any sign of new things happening, any reform taking place in the country with respect to take us to the situation where we have universal health coverage. So that was all from me. Next one, please. Okay. And these are some of the titles that have been published over the years, bringing together the Bangladesh story. And the middle one is the one that I was trying to present today, of which I was one of the editors, but there were 103 authors, and many of them are actually present today in this. The final slide is the next one. So this one shows the 20 chapters that are there in this book, and this book is available via the Amazon for both the ebook as well as the hard copy. So with this, thank you very much for I'm sorry it has taken too long probably, but I really enjoyed presenting it to you. But if you have any questions, of course, please do ask. Thank you.
Yeah, thank you, Professor Mushtaq Chowdhury. It was really amazing to see the journey of Bangladesh over the decades and how we reached to the place where many of us, or perhaps our people from our past generation, couldn't even imagine that we would be there at some point. So you were kind of a first-hand um, person who experienced this journey firsthand, being part of a remarkable NGO called BRAC, and also through our other initiatives. So thank you so much to share your journey, which is also Bangladesh's journey. Now I'd like to request my colleague Kang Soo to facilitate the question answer. I guess we already got some questions in the chat box. So perhaps we can actually start with those questions, and then we go for other questions that we may have from our audience. And mindful of the time, we have less than 10 minutes, but perhaps we can extend for 5 more minutes if you all agree. Kangsu, are you going to facilitate the question answer?
Sure, yes, and thank you, Tafid, and thank you, Professor, for your comprehensive presentation about the Bangladesh health system. We also have some questions in the chat, and the first one is from Fu Shanti, and he is asking about, it is contested that Bangladesh is self-sufficient from pharmaceutical aspect, but he also would like to know how the antimicrobial resistance policy reconciling with Bangladesh pharmaceutical expansion. So this is the first question.
Yeah, I mean, we are seeing an explosion of AMR in this country, and one of the chapters that we have in this book is on pharmaceuticals, and it talks about how the use of the antibiotics and others have really led to the rise of the AMR in this country. There has been a number of research on this, and has been trying to see how to deal with this. And the government is working on that. Some of the NGOs are also trying to address this question.
Yeah, it's kind of a challenging for all the low and middle income countries, the AMR policy
Absolutely.
integrating into the pharmaceutical expansion. And
Absolutely.
then the other question is one of our colleagues from AMU, and she also would like to know about how the community healthcare workers recognized officially in the public health system, for example, MOHP rule, and if it is, how did the country get there? And one of her projects are mostly based in Cambodia, and in Cambodia, community health worker is an integral part of the health system, but the incentive recognition training system can be challenging for community healthcare workers to be effective in their role in Cambodia. So she also would like to know how in Bangladesh the community healthcare workers are recognized officially.
Yep. The community health workers are there both in the government system as well as in the non-governmental system as well. So in the government system, all the health workers who are in the field, they are part of the system, so they get salaries. But the community health workers which are in the non-government system, very few actually receive a salary. So they are in real sense volunteers, and there are problems with that, as I was trying to mention, that you have to have a system of incentive that has to be sort of built into the system in order for them to continue working. And the situation has changed because also of the country's socioeconomic progress. Because in the 70s, when the program was started, there were the opportunity cost for women to be part of the community health worker was much low. But now that there are more opportunities for them to get gainfully engaged is much more. So you don't get the attention and the participation of community health workers as you used to get. Also, that the literacy level, the education of the community health workers has also improved a lot. So you now get better educated community health workers who are able to provide much better services than probably their predecessors. And also, when you move to from the rural areas to the urban areas, in the urban areas, the opportunity cost is much more even. So if I mean there are more jobs available for women and so there are many sort of challenges that the community health worker programs are facing in Bangladesh. And I have been involved also in other studies that was done on community health workers in other developing countries, including East Asia and so on. And very similar situations are being felt. But one thing which is very clear and accepted by all is that the role for community health workers is still there in order to achieve global health.
Yeah, and I also agree with that. Mainly the community healthcare worker is a major role in prevention, treatment, and then providing the essential healthcare services in the primary healthcare level. So it is better to have that kinds of official recognition from the government, or there should be some mechanism to recognize private community health workers. And then one question is related to the GIS and remote sensing things. So how the Bangladesh government planning to strengthen the health system to establish data-driven decision making utilizing GIS or remote sensing, and what mechanism can be employed to reach remote and how to reach community and improve access to healthcare services?
Yeah, the government has sort of several schemes in order to use the
Digital health.
Digital health in the health system, both in the monitoring as well as in the actual provision of healthcare as well. And this is not only the government, but also there are several sort of institutions in the private as well as the NGO sector, which are also trying to provide the digital health services. But we haven't. I hate to say, but we haven't really come up with a really robust system as yet.
And then one of our colleagues from SCGHI, she also would like to know about the Bangladesh effort to strengthen collaboration among various entities like public, private, academic, and NGOs, that kind of multi-sectoral collaboration in health transformation. And are there any specific modality or engagement in place to foster such collaboration?
Mm-hmm. Well, there are collaborations between the government and the NGOs. There are many of the programs which are jointly carried out by the government and the NGOs. And I mentioned about the tuberculosis program, which is jointly run by the NGOs and the government. So apart from that, there are many civil society institutions which have come forward, for example, under the umbrella of Bangladesh Health Watch, which is a civil society voice to really take any health issues with the government, and it is a organization of many civil society institutions and individuals. So similar kind of sort of multi-participant sort of organizations and actions are being seen in this country a lot.
Thank you. Council, do you have any more questions?
One more question from the participant, if
Okay.
the times allow. Yeah.
Yeah, perhaps we started 3 minutes late, so perhaps we can use 3 minutes injury time.
Yeah. So this is the last question from the audience. And then the question is about health-seeking behavior among people in Bangladesh and how this health-seeking behavior changes over the past 50 years and how has this impact overall health outcomes?
Well, it has changed to good, and in some cases it has changed to bad as well. So it's not that everything that has changed is good. The smoking is there. For example, the drug is a major problem here. So those kind of sort of behaviors are seen, and also that the behavior of the healthcare workers is also a major issue here. The behavioral aspect of that. So things are changing, and we have to go a long way to really address many of these.
And I think he would like to know about the health-seeking behavior rather than their health literacy and rather than their behavior towards their health. So
I see. Okay.
Yeah.
Well, the health-seeking behavior is changing, obviously, and people are since the private sector is coming in a big way, and they are easily available. So people are moving more into the private sector, but then it also comes with problems, and as you know that. One of the issues that Bangladesh is facing is the proportion of births which are due to cesarean section. And when the WHO recommends 15%, the cesarean section is about 45% here. And 80% of those actually happen in private facilities. So people are sort of going into the private sector, but that's happening because of the problems with the public sector. Until the public sector is improved and the private sector is also regulated well and supervised, there will be sort of continuous problems.
Yeah. Anything else, Council?
Nothing from the audience. And then if we have 1 minute, I have one quick question.
Yeah, please go ahead.
Dive along. And then what I learned from the professor presentation is like most of the development and health sector is a donor driven in Bangladesh. So now there is a transformation from the donor driven to the financed by the own government. So if these kinds of things happen in Bangladesh, is there any sustainable plan after the donor revoke their project from the country, and how it can be sustainably provide the existing service to the population?
Well, first of all, I want to sort of challenge what you said, that it was a donor-driven thing. It wasn't a donor-driven thing. It was the Bangladeshi NGOs. They sort of came forward and thought that this is a problem that need to be tackled, and they developed the programs. For example, the ORT program, the donors were not part of that, so they developed it. And then after it was developed, they sought the help of the donors. So it was it was not a donor driven as such, but it was donor supported, of course.
So it's kind of co-creation.
Co-creation, you can call it.
Yeah.
But that's the new buzzword, right?
Okay.
It was a co-creation, but now with the change in the global scenario, where the donor money is kind of drying up. So the NGOs and other development organizations are now facing new challenges of how to support their activities, and that's something which is a big challenge for them. Some of them are moving into more social enterprising, setting up social enterprises and so on, in order for them to sustain.
Thank you.
Thank you. So we are already 6 minutes over the time. So although we are still getting questions, and I see participation, I mean, it's a true global health type of webinar, I must say, because we have audience from Singapore, and not just Singapore and not just Bangladesh. I see audience joining from Australia, UK, and all over the globe. So it's an amazing experience, and I'm really honored to host you, Professor Mushtaque Chowdhury. It's an honor to be to listen to you and to create a platform in Singapore to talk about, discuss about, learn from the experiences of a low and middle income country sitting in a high income country. It's an humbling experience, I must say. So thank you so much for your time. I thank all the audience for their excellent questions, for their presence in this webinar, and making it a fruitful and an enlightening event. Thank you so much, and I look forward to more such events in the future. Thank you.
Thank you very much. Thanks, everybody.
Thank you.